So the patient comes in and goes, I am worthless. I'm just, terrible things about themselves. And a mentalizing intervention would be to recognize the patient isn't mentalizing now, right? So where were you just before you got into criticizing yourself so much this morning? And you will often discover the type of things, probably something that was important for the patient emotionally, that got them into thinking that way in the first place.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arnaud, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area. Good morning, everyone.
Good morning.
Good morning.
We've got a few voices here today, and it's the new year. We're recording in 2026. It's January 2nd, just the day after New Year's. I'm still technically off. I know Dave's in his office, and our guest, Daniel, is at home as well. I hear it's very snowy, probably cold in Edmonton. So I hope you're all enjoying what 2026 has to bring.
We're trying to stay warm.
I did my first family cross-country skiing this yesterday, so we're making the most of it.
Very nice, very nice. So today we have a guest with us, Dr. Daniel Rochman, and very excited for today's discussion as we're going to be diving into eating disorders and mentalization treatment. And before we even, introduce that topic, wanted to introduce our guest, Dr. Daniel Rochman, and he is a registered psychologist in Alberta, Canada. He has worked since 2011 at the Eating Disorders Program in Edmonton at the University of Alberta Hospital. Dr. Rochman is an assistant clinical professor at the Department of Psychiatry of the University of Alberta in the psychiatry training program, where he provides training in psychodynamic therapy. He is also an adjunct academic colleague at the School and Clinical Child Psychology program of the Faculty of Education at the University of Alberta, and a part-time private practice psychologist at the Center for Psychodynamic Insights. He is trained in mentalization-based therapy as a practitioner and supervisor for adults and adolescents by the Anna Freud Center of London. So welcome, Dr. Daniel Rochman.
Thank you, and thank you for having me.
I have been excited. We have had this topic, on our list of things to discuss on this podcast for quite some time. And now we finally have an expert to speak to it. And we'll have a conversation around eating disorders or disordered eating. I actually want to clarify with Dr. Rochman what the correct term is at this time. And then, I think this is good timing too, right after the holidays. And there's been probably a lot of food and events that people have been to that it might be very topical as well.
For sure. And the holidays tend to be a stressful time for people with eating disorders. I just want to say before we get started, if the listener is somebody with an eating disorder, just be mindful, because I might be saying things that might potentially be upsetting. So seek appropriate help. And let's just remind the audience that this is not professional advice. It shouldn't be a replacement for a proper consultation with a professional. So let's get into this a bit, because there's a lot to say about eating disorders. And when we talk about a disordered eating, we are getting into something that it's a behavioral manifestation of psychological distress. And I want to start with that. And it's a type of distress that fundamentally alters the person's relationship with food. It evolves into an obsession that can compromise so many things in the person's life, like the sense of self, and they cannot return to a normal way of eating. Beyond just the physical symptoms, the eating disorder serves as a reflection. It's a conduit for profound fears and insecurities that the person has. So it of course impacts your quality of life, and it reinforces in the person a sense of inadequacy.
Mm.
The most well-known eating disorder, if we're going to go by the DSM and the formal classifications, I think is anorexia, which is a restrictive type of eating in pursuit of weight loss. Together with this, there are medical complications that come as a result of that weight loss. And it tends to be quite persistent, sometimes coming with other methods and maneuvers to lose weight, like excessive exercise. So all of a sudden, the person is exercising not in a way that most people exercise. It's done for a specific purpose, and it's definitely not enjoyable, and the person feels that they have to. I would say that's a marker when the person feels that they have to eat in a certain way and they have to exercise a certain amount and they just can't stop. So I would mention also that it's very likely, and this happens in most cases, I think over time, the person finds themselves unable to lose so much weight and eat in the way that they have set themselves out to eat in pursuit of weight loss. And then there's a loss of control. So typically, the person would restrict themselves from food most of the day, and come evening or night time, they find themselves binging and then purging because there has to be a compensatory behavior.
Mm.
So then we have the anorexia, binge purge type. So there's more,
Yeah,
but it sounds like you guys have something to say, right?
I do. Daniel, I think what you mentioned, like right off the hop, when you said a behavioral manifestation, that really caught my ear because it had me start to think about etiology and, why food, why eating, why does that behavior get highlighted or become the sort of result of distress? Is there any research into the etiology of eating disorders? Why food becomes the manifestation or the control of intake and output?
Yeah, I don't think there is one final answer to that. Most of the time, I find that to be a very personal thing. It's very
Yeah.
unique to the individual. We do know of some genetic proclivity for this to happen, but I think everything plays a part. The
Mm.
person's environment plays a part. Sometimes the culture plays a part. But when it comes to the person in front of us that we're trying to treat, it's not always clear for us sometimes. It takes quite a long time to disentangle that. But for sure, in an environment and for a person where they discover all of the sudden that a change in their eating pattern does something to them, does something to their sense of self or their levels of stress, they can really get caught up in trying to manage some of their emotionality or some of their problems through the food.
Yeah, Daniel, as you were talking too, I was thinking the description or the definition of an eating disorder, and especially, where someone might be hospitalized for it. A lot of the listeners won't be familiar with that, but in terms of like at least anecdotally for myself, speaking to a lot of adult women, reflecting back on through their lifespan, that at some point this is a very common experience. And I don't know the exact statistics, but for a lot of, teenage girls or young adults in the university population, where this binging, purging, or restrictive food intake. Do you have any more specific kind of stats on how common this actually is? And for the listeners listening, you might be reflecting on your relationship with food over your lifespan.
I don't know, and nothing comes to mind, and I think there's a lot of research out there available for people to consult. But anecdotally, from patients who are in university, and many of my patients are young patients, uh, it seems that this is quite widespread. Many people undergo a period of their life or particularly stressful situations that lead them to change their approach to food. They relate to food in a different way, and they find themselves doing these kind of things for sure. I want to address something that often comes up in conversations of this type, and it's that I think the media, movies, TV shows, and so forth have put a lot of focus on young women, but we know now that eating disorders affect men too.
Mm-hmm.
It's not very clear what the statistics there, but I have heard the best guess is between 10 and 25% of men are among the population of those who have eating disorders. So just to make that clear, of the total amount of people that we know have eating disorders, about 10 to 25% are men. How many men in the general population, I honestly don't know, but I can say they're much less likely to seek help. So that's something to consider.
That was actually my follow-up question
Yeah, me
because,
too.
yeah, I even just, in terms of your experience over the years, have you seen more men coming forward? I know in my men's group, there has been more talk of problematic, relationship with food, and that this was never the case, 10 years ago. We'd very rarely have any men talk about this as being a problem for them. And I think, it is typically more of a gendered focus when, at least on the research end and for my own kind of training. But this is shifting, I think, maybe it's always been there, but it hasn't been talked about or yeah.
Yeah, well, I think very, very slowly. I honestly don't see many men stepping forward for help with this specific problem. There has been a shift. It's a slow shift. I do see a few men in our patient population, but they aren't to the level of the 10 or 25% that has been reported in research. So there's probably many men out there that have these sort of problems, but they never think or they never want to, or they don't feel that it's the right thing to do. Let's say also that aside from what we know that this affects all ages too, not just all
Mhm.
genders, all ages too, and all cultures. And I'm bringing this up because the common misconception is that, oh, this is something that just affects young women of upper middle class. So it runs the gamut from rich to poor. It doesn't make any distinctions. But I want to go back a bit to mentalizing because that's something that has been very interesting and useful for me to know as a clinician, and I don't think it's talked about enough in our field. For some reason, in eating disorders in particular, I think people tend to just embrace one way of working and they don't deviate from that very much. And I do think that mentalization-based therapy has made a unique contribution. So let me just organize this thought because David pointed out that I started by mentioning that this is a behavioral manifestation of underlying psychological distress. And mentalizing has a lot to do with that point in particular because it's at the crux, like right there, in terms of how we understand behavior. And it's when we think of our own behavior or somebody else's behavior, and we try to understand, come up with a thought of why that behavior is happening, and we connect it to an underlying mental state. And this is a lot of words for something that we do all the time, every day, right? Well, that capacity is mentalizing. And why is this so relevant to eating disorders? Because people with eating disorders, whether it's themselves thinking about their own behavior or somebody else thinking about them, it brings up behaviors that are very perplexing. So it challenges mentalizing. It challenges mentalizing in the sense that, oh, what happened to me? Why am I doing this? Or somebody else that looks at their family member engage in a change in behavior with respect to food, and there might be like, wait a minute, what is happening here?
Yeah.
These are situations that challenge our mentalizing capacity.
And for any listeners who need a refresher about mentalizing or mentalization, if you haven't listened to Dr. Mark Nichols' episode on mentalization and treating borderline personality disorder, definitely go back and you'll hear a more in-depth description of mentalization. So I'm wondering, Daniel, if you could even review with us, if you're able to. I know mentalization is the work that you do. But in sort of the, I guess, quote unquote mainstream, what are some other ways, or perhaps even programs or systems that people have tried to put into place in terms of treatment of eating disorders, and what makes mentalization different?
Well, I think every form of therapy has made an honest and brave attempt to try to address the problem of eating disorders. But the truth is that a lot remains to be done. Therapy is not effective more than in 0.5% of the cases in general. So from the point of view of psychotherapy, there's a lot to do. The other problem that we have in the area of eating disorders is that it commonly presents with a lot of comorbidities. So that's a challenge in terms of research, because they've tried to find people who just have an eating disorder and nothing else. So that's hard to do. But I can say from the behavioral perspective, I would mention the home-based approach from the Maudsley line of interventions, which is a behavioral approach. It can be very helpful, and it has been helpful, particularly in adolescent patient population. And it's an approach where they use the family, particularly in general, the parents, to help refeed their child. And that has been helpful to a degree. It doesn't work all the time, and it doesn't seem to be as helpful when the patient is older. I would mention the cognitive behavioral approach enhanced for eating disorders. That's quite popular. As we know, it focuses on the cognitions that arise in combination with an eating disorder, and that's quite popular as well.
The one that I've come across a little bit recently is like IFS, the internal family systems,
Yeah.
with Richard Schwartz. Do you see any of that in your work, or is this something that's kind of not here yet?
David, I honestly haven't heard much about that, just somebody mentioning it, but I don't know how it works and whether there has been any research in relation to it. But I will say something, regardless of the specific type of psychotherapy that you use, you do need to be open-minded. Don't go into treating an eating disorder wanting to be too loyal to your approach, because you might forget about the patient. You have to do what works for them. And don't be so brave as to just go at it alone. When things get complicated, you are going to need a team. You're going to need a psychiatrist, because this has medical issues, and you're going to need a dietitian to work in close association with you.
I love that suggestion, Daniel, because I work with a number of early year psychologists, and sometimes they get so married to a certain approach, and they beat up on themselves when something doesn't work. And it's like, you know, let's think about not just the approach itself, but let's start with your connection with the person. You know, the adolescent or the adult right in front of you. What is it that they need? You know, whether it's eating disorder, depression, like you said, there are so many other comorbidities or concurrent disorders that come with it, such as depression, anxiety, past trauma, all sorts of other things. And we still have to treat all of that in addition to the eating disorder.
Oh yes, for sure. So, Andrew, you have just brought up so many things, and this conversation can get so enriched when somebody
We
makes
told you,
those
Daniel, this could go all
yeah.
over the place.
Oh gosh, I don't think I knew what I was getting into. So, where to start? I think it's a common experience for clinicians that they feel that they're not doing enough, that their approach isn't working, that they want to give up, or that they want to go with what they know even stronger, like doubling down.
Hmm.
Okay, all sorts of things that tend to happen, and in a way, they're connected with the type of psychological problems that the patient has. Now, let's think of this because many people with eating disorders, they never feel good enough. And all of a sudden, you get a therapist who's not feeling good enough.
Hmm.
So I think from the mentalizing slash psychodynamic perspective, something really powerful and interesting is happening there. In the relational field, with your type of relationship with the patient, these kind of things are going to happen. Sometimes it goes beyond that and it starts to feel like some type of power struggle, right? The therapist is nervous because there hasn't been good results and they want to move forward or show the team that they're good therapists. And, who knows what happens in their minds and the type of stress that they feel, right? So all of a sudden they find themselves in a power struggle of the type of who's going to control who here, is the therapy going to win or is the eating disorder going to win? Something
Uh,
of that sort.
I got chills when you said all of this, Daniel. Like if a patient is feeling this way, inadequate to begin with, and a therapist then also feels inadequate, like what's happening there? When you said that, I was like, whoa, that's powerful.
I will say that I wouldn't be the first one to recommend that this needs to be done with some level of supervision. As a clinician, you do need to know yourself quite well because of this type of countertransference that tends to happen. The more you work with this, the better you know when the disorder, the environment, the patient inadvertently is pushing certain buttons, and you need to know them because it's going to affect the type of interpersonal, intersubjective field that gets created with the patient.
Yeah, and we could keep, there's so many pathways here. Yeah. For the listeners that aren't aware, countertransference and transference, right? It's kind of what we project onto either the client or the client projects onto us in terms of their feelings about us, their interpretation of us, and psychodynamic, that is heavily focused in that approach. So we're not going to spend a lot of time there, but it's very important to understand kind of the dynamic between the therapist and the patient, or the clients and the therapist, and much like, other relationships as well. But especially when you're trying to help someone, there is a lot of good people, good clinicians, a lot of clinicians that specialize in this area, at least in the Edmonton area where I'm from. So I will quickly refer out because I know there's like, this is not an area of specialization for myself. But when I'm working with someone, say for months or even years, and then this emerges as a secondary or a tertiary kind of concern, that's where I'll do a bit of work around it. But also knowing that, like, I don't know what it's like in Toronto, but there are a lot of good clinicians that specialize in this area that are a quick phone call away.
There's so much to say in relation to this, but countertransference doesn't need to be any mysterious concept. It's something that somebody affects us in a certain way. Maybe it's something that makes them feel uncomfortable and they make us feel it. But to take it down to ground level, maybe you're a concerned mom or a concerned father, and you see that your daughter or your son aren't eating properly, and this goes on and on. And emotions start to participate in this. All of a sudden, you find yourself frustrating. You want to control your child. You're saying things that you normally wouldn't. This type of emotional reaction, that's what we're trying to look at. And it is a way to try to understand what happens in the therapy as well. Because let's face it, clinicians of any sort, psychiatrists, psychologists, dietitians, they're human too, and they're going to be affected. So when you're treating an eating disorder, you need to be mindful of these things too. All of the sudden, and it doesn't matter which type of therapy you have embraced, you find yourself, for example, educating your patient about things like metabolism and micronutrients and so forth. And it's very interesting to observe because clinicians want to do this to explain, look, you need a protein and carbohydrates and vegetables in your diet, and all that stuff is fine, but it just has its proper place. It needs to be done in a mindful way. And what's funny about that is that we oftentimes find patients that know more about that kind of stuff than us. So what's happening? Well, we believed as clinicians that it's maybe a lack of information. The patients don't know. But they do know, and nevertheless they engage in these behaviors. So, how do we think around that, and how do we organize our thoughts when we're trying to help them?
Daniel, you mentioned emotional reactions, and emotional reactions from others. And I wonder if there's ever harm that can be done from others' emotional reactions, namely perhaps caregivers or peers or even a therapist, because I think earlier in our discussion, you mentioned that with eating disorders, there's a high level of self-criticism or perhaps a sense of inadequacy. And so I'm just trying to piece it all together a little bit here with mentalization. There's this piece around, okay, how does someone else react to what I'm doing? Or what's their perspective? Or what do I think someone else's perspective is? So I'm just thinking when you said emotional reactions, can there be harmful, indirectly harmful? I don't think anyone goes up to their children wanting to harm them, with their reactions, but can there be indirect emotional harm with their reactions because of how the patient or client might be sensing that particular perspective?
You're going right to the heart of mentalizing from my perspective, because mentalizing is about developing a curiosity for the mind. It's about understanding that when we are unfiltered and we just go with an emotional reaction, we're probably not mentalizing, right? It's like the mind starts to follow mindlessly a sort of script that's overdetermined by the power of the emotion. And one thing we know is that uh, strong emotions really challenge our mentalizing behavior. And when that happens, we stop being interested in the person as a person, and we stop interested in how they are in the moment as a mind in a more comprehensive way. And so what I'm trying to say is that we forget to ask things like, well, hold on, let's just kind of slow down here because things are getting very intense.
Mm.
What's going on with you today? What's up with you? Can we get a little bit into that? Right? And this is something that a clinician can do, but I think a family member can do as well. Because otherwise it's like you get carried away by the emotional storm, right? And then you're going to stop mentalizing. And one thing that we know in mentalizing is it needs to be it needs to be kind, it needs to be done with patience, it needs to slow down. It needs to go beyond the behavior. It needs to understand these type of things that what pushed your buttons for these emotions to come up. Okay. So it's an attempt to, all these questions, what are they trying to do? Well, they're trying to restore a capacity that we might call the reflective capacity, right? It's an attempt to restore this benign curiosity that mentalizing is trying to capture as a concept, right? So where do we take it from here? I feel I lost my train of thought. You said other interesting things that escape my mind in this moment.
Well, that's why there's three of us. So when Andrew was talking, I was thinking about shame and, even like body image. And as caregivers, as parents, if your child is quote unquote overweight or underweight, and you take your child into the pediatrician and they put them on this growth chart and it shows percentile, like we can have our own responses to that may not be helpful, that might actually promote an eating disorder later on. I'm
Yeah.
totally looking at you, Daniel, to correct me. Um,
Well, let's. I mean, that's already enough. You kind of help me out here. That's a situation known to instigate the blame game. And as soon as you have stepped into that area, you're probably not mentalizing, right? And one thing we know, a shorthand here to remember is non-mentalizing begets non-mentalizing. So you treat the person in a non-mentalizing way, and they react in a non-mentalizing way, and you don't want to go down that road. At the same time, if you were to remember a couple of things as you get dragged into a blame game. One common misconception in this area is that it has to be somebody's fault or there is one cause for the eating disorder. Well, research tells us it's not that way. It's a confluence of things. Because look what happens. We blame genetics. You had it and your mom had it and so forth. So that's the explanation. Well, okay. If it's not genetics fault, it's the mom's fault or the kindergarten teacher's fault. And then we blame the patient. And then when that doesn't work, we blame social media. And so it's not one thing. It's not one thing. It's a complex confluence of factors that lead the patient towards disordered eating, and there's many factors that might keep it going. So let's try to remember that.
How do you not fall into that trap though, Daniel? Because I hear from caregivers all the time, especially when it comes to disordered eating, like how frustrated they are. Like they've gone to programs and they've gone to the hospitals and they've seen X number of professionals. And I feel their frustration. I feel their pain and, years of managing and coping. And it just gets to the point where they're like we're fed up. Like, what else can we do? And so I'm just wondering from your years of work with families and caregivers, what do you tell them? What do you remind them of in terms of being able to continue to mentalize and be compassionate towards the needs of their child?
Yeah, well, it's important not to get too focused on one of these problems, such as I think the typical scenario is that Everybody's so concerned about the medical problems or about how much weight the person has lost. So I think the body of the patient has an effect on us, and it has an effect on family members. But when that becomes too captivating, well, guess what? They do forget, and we forget sometimes about the patient as a person. What other things have been going on? If the patient is in your office telling you, I feel fat, right? And I've seen this in the literature, clinicians recommending to say, well, fat is not a feeling. Well, I would suggest that that's not the right approach. The right approach is to become curious about what they're trying to tell you and what type of mind, what type of personality, what type of psyche is in your consulting room trying to tell you these things. What does it mean? What other feelings are happening concurrent with that feeling big or feeling full or feeling fat and so forth? I'd like to give you an example that comes to mind. A patient I had some time ago would very often say that that she feels full. But nobody had asked her about the details of this experience. What's it like? What type of things were happening before you felt full? Because it's a moment of loss of it's a moment of loss of mentalizing. It's a lack of a capacity to think properly. So they go to a place like that, which has very powerful effects interpersonally. Part of them is that, as I said before, the clinician cannot mentalize, so they don't ask these questions. But as we got into the details of her experience, she realized, oh, wait a minute. I woke up feeling full. And then so we realized that feeling full doesn't necessarily have to do with the last meal because she had been sleeping all night. It can't be a feeling full out of food. Well, so what is it? Isn't that curious? And then we came to understand in many different ways. I'm not going to get into the whole complexity here, but that it is possible in people with eating disorders that what happens to them emotionally gets somehow represented in the way they feel their body. Okay, so it's something that is emotional, something that usually we would think of as being of the mind, of being of an emotional experience. Instead of that, it gets reflected in the body, and particularly it tends to disturb the relationship between the body and the mind. So as she felt full was a sense of, the emotions that she was feeling were also very big. They were taking over their mind. But she didn't feel it in that way. Instead of that, she felt full.
So pulling out a body mass index and a weight scale and telling her, that she was, or no, that was the previous example with the feeling fat, right? Like that is not the approach you are taking here. You're approaching this from a very curious, trying to understand from the patient's perspective, that person-centered approach. And yeah, I'm just really kind of reflecting on what that looks like in all therapy, right? To kind of be curious rather than come at it from an expert perspective and that you are going to teach them something that will help them, change, especially in this area.
I was going to say, well, I'm assuming that so many adolescents and patients who have an eating disorder, they probably get lectured enough already, whether it's from a partner, a parent, a professional, they're probably hearing the same thing over and over again. about the dangers of not eating or, having compensatory behaviors and how dangerous that can be. I'm sure they hear it all the time. And so I just wonder sometimes, what is it like just to be treated like a human being again?
Well, it's hard because it's hard over time to maintain that stance. And I will say, let's organize the thoughts here a little bit because I think going back to how people offer therapy and how they try to address these problems, if you look at it historically, right, there's been approaches that are just focused on the medical perspective. They're only focused on the body and they forget of the mind. But you can go to the other extreme and you will find approaches that are only talking therapy will solve this problem. And they're both misguided to a certain extent, which is you can forget the other side of things. Yes, there has been therapists in the past that have advocated for a purely talk therapy, and they don't see that there is a patient there inhabiting a body that is disappearing, and that needs to do something, right? So it's not one or the other. We have to be able to do both. We have to keep in mind the patient's mind and keep in mind the patient's body. But the problem is that they can both bring the therapist to a place where they're much more interested in changing the patient than in understanding the patient. And when emotions run high and people are nervous and anxious, right? The impulse to change the patient becomes much stronger, relatively stronger.
Well, if someone is scared, right, for the well-being of their child or their patient, right, if they've lost weight to a certain extent that they have just been admitted to the hospital, I can see that. I can see where this needs to change, and there's this urgency to it that, again, like you were saying earlier, you lose that mentalizing perspective. You start, maybe demanding things or enforcing things that are, needed in that moment in your mind. Like there's this script that says, I need to change this. And I see this with, a lot of addictions and other areas too, right? Where it comes from a place of concern and worry.
I'm just thinking for some of the clients I work with, when I work with families, like so many come and fix the problem, fix the problem, fix the problem, right? And I can only imagine at a clinic like yours, Daniel, where they may come in and just be like, okay, fix my adolescent child, fix my young adult child. And rather than thinking, hey, we need to understand your child. We need to understand the young adult.
Both of you make a good point here and are bringing up a central dilemma for treatment teams. It's interesting to see what happens with patients who have been to other therapies and sometimes that hasn't worked very well. One patient was surprised at the third session, I think, and a young patient, a teenage patient, and she tells me, "But wait a minute, Daniel, you're not going to tell me what to do?" And I said, "Well, that's very interesting. I'm not going to tell you what to do, and especially I'm not going to tell you what to do right now because I don't think I have understood you yet, and I'm more interested in that than telling you what to do." You see, because mentalizing invites us to adopt a not knowing stance, right? And the knowing stance, which that tends to be a problem, particularly in the treatment of eating disorders, is that I know what the solution is, right? But then you get into, if you want to do that as a clinician, that's fine, But just be aware that you're getting into a type of relationship where the patient is going to see you very likely as trying to tell them what to do. Okay. And where is that a problem with mentalizing is that they really stop being interested in how they got to where they are and what's happening in their life. Right. So please, doctor, when this doesn't work, tell me more what to do. And it becomes a problem. If you are aware that the situation is becoming problematic, then it makes it all the more urgent to tell the patient, look, I think this is not going the right way. You want to try to rekindle mentalizing. If you are able to surprise the patient to some extent, make the patient more interested in the therapy, then you're back into a good a course, right? And it can become complicated. It's like navigating a ship through a storm.
You mentioned earlier, and I know we're getting closer to our time, but I think it was kind of in passing around perfectionism, and I wonder if you could comment on that in terms of maybe even from the patient's perspective or the client or the therapist in terms of, that combination of that highly perfectionistic personality trait.
Yeah, thank you for reminding me of that. It's a central issue in eating disorders. It's a personality trait that we see very often, which has many sides. I think perfectionism in particular has been investigated, and it is really complex. But to say something that I think might be helpful for the audience is that I don't think of the self or the personality as a unitary entity, right? What happens in perfectionism and self-criticism, really, you can think about it this way, is that one part of you is criticizing another. One part of you is demanding to be to be perfect from the other, right? And this is it reflects a lot of anxiety, and it reflects a lot of problems in the mind. And I'd like to say that this is not privative of eating disorders. There's other pathologies that have this kind of structure to them. And so the perfectionism comes from this attempt to please this demanding part of you. But guess what? The approval, it's like it never really comes. So you do more and more and more, and I have to be perfect, and my body has to be perfect, and I have to be only a certain way, right? And this is why so many times because they don't get that internal approval, they will try to get approval constantly from other people, and that puts them in difficulties in relationships as well. So that's what I try to keep in mind, and you do have to know about these things as a clinician to try to help them, because it's tied into. I'm going to say a little bit about this. I wish we had more time.
I can keep going for a while.
The self-criticism, the perfectionism, I mean, this is so fascinating and sometimes mind-boggling. It interferes with the self-perception, right? That's where it's this kind of delusional aspect almost of the eating disorder, is that they don't see themselves the way we see them, because we know that the evaluative process, this demand for self, perfection, is embedded in the perception of the self. So the person is looking at themselves in the mirror in that moment, in the way the image is organized in the mind. We know that there's an evaluative process that's embedded into the perception. Okay, and not surprisingly, they come to hate their body. This criticized, diminished, hated part of themselves is imagined to be in the body. So they attack themselves. We see a lot of self-harm in eating disorders.
I wonder though, Daniel, as you were talking about the self-critic and just beating up on themselves and constantly not living up to a certain expectation, I wonder if that's even more compounded because as you're criticizing yourself and you're looking and seeking for validation from somebody else, anybody can bias or skew that perception from the other person and go, oh, that person didn't actually mean that. Or that person's positive words are actually a slight. And then on top of that, now the complexities, I think, of social media too. Like we don't even know the personalities on social media, but they're making comments that somebody now might be taking it personally. And so I wonder if there's this sort of compounding effect, negative effect of this self-critic where yeah we're self-critic but then there's like others and people who we don't even know that just all comes flooding in.
Yeah, yeah, for sure. And they are all versions, examples of loss of mentalizing in the sense that all these comments they are in a way an insult to our reflective capacity. It makes us see ourselves just in that one way. So it's like it's a restrict. Imagine you get information about yourself, but only from one channel, and you're tuned only to that one very criticizing channel, and you cannot expand your perspective. You don't you don't trust other comments, you don't pay attention to them, they don't mean much to you, right? So you can look at it in this way. You'd ask a patient, what do you do when somebody pays you a compliment? Ah, well, it doesn't matter very much. They only stay with the negative comments, and those are the comments that kind of stay in their mind, and they can't trust anything else. So something is happening to their reflective capacity, you see, because they cannot see it in any other way, and that's an indication that when it comes to beliefs about yourself, mentalizing has been lost. And so we try to implement a type of relationship in the consulting room, and this can happen whether you practice mentalizing or not. Something that will strengthen, regenerate, reinvent, invigorate the mentalizing capacity for you to start to feel that somebody can relate to you as a person, that they're interested in how you get stuck in these negative comments that are directed towards yourself, right? And so it's not an easy, straightforward thing, and I can't say that I have some kind of recipe for how to solve negatively balanced self-criticism, right? It's a difficult thing, and as I said at the beginning, it has many angles to it. But don't give up on your patient. If I have to say something, don't give up on your patient. They come to appreciate the effort that you put in try to understand them, particularly in a way that has been different from the way other people have understood them and the way they understand themselves.
So, with that self criticism and perfectionism, there's a lot of judgment, right? I need to do this, or if I don't do this, like, so when we approach them with judgment, right? Like you're saying, get curious, try to understand rather than judge or tell them what they need to do. That I can see in a lot of ways in therapy, right? This idea that someone is already feeling not good enough, and then we come at them with telling them what they need to do that they haven't been doing, that can feed into this and make things possibly worse because now they're even more critical of themselves because they're not able to do what the therapist has told them they need to do. So if we can suspend that and appreciate them as human beings, right?
Yes, exactly. And as a technique, for example, from the mentalizing perspective, is you don't you try not to join in non-mentalizing, right? So the patient comes in and goes, I am worthless. I'm just, terrible things about themselves. And a mentalizing intervention would be to recognize, okay, that's the patient isn't mentalizing now, right? So where were you just before you thought that? Before you got into criticizing yourself so much this morning, what was going on? And you will often discover the type of things, probably something of an interpersonal sort, probably something that was important for the patient emotionally, experientially, and so forth, that got them into thinking that way in the first place, right? So that's why we pay a lot of attention to the process. And I haven't had the chance to explain this today, but mentalizing is a process. So you see the process happening. And when they're in that area, you want to try to do things to take them out of that area. Utilize whatever technique you have, but it's something that you don't want to get them further into the self-criticizing mud. And
Yeah.
remind them that there's another focus out there. There's a lot of things I haven't been thinking about this morning, and that's how I got into the self-criticizing mud.
Before we hit the record button today, Daniel, you had spoken about possibly touching on speaking about how to approach, whether it's your child or student or someone close to you, if you suspect that they may be struggling with an eating disorder. And when you mentioned that earlier, an example came to mind actually, because my wife is a high school teacher. And on multiple occasions, she's been teaching now, I think, 17 years or something like that. And I remember on multiple occasions, I think as recent as last year, she was telling me that she was on a school trip. It was an overnight trip. And she noticed that one of her students wasn't eating anything, like very, very, very restricted. And she and her colleagues suspected an eating disorder. And I think this is one of those occasions where, as a teacher, you're not trained to suss out an eating disorder or to approach somebody who may have an eating disorder or a parent. So I'm just wondering, from your perspective as the professional, any tidbits, any advice or suggestions that you can provide to caregivers, teachers, other individuals, what to do?
That's a tough one, Andrew. But thank you.
Sorry to put you on the spot.
Thank you. No, yeah, thank you for that question. I think you have to know the child. I think the person approaching the patient needs to be something that the patient can trust. Keep in mind that they don't usually see the problem the way you see the problem. For us, for the outsider, it is a problem. But for them, it's a procedural way to try to solve emotional problems in the self. So don't go there thinking that the patient is going to think like you. They have another type of mind. They see the problem in a different way, and it's very likely that they kind of see it as a solution more than as a problem. Okay, but it wouldn't be in line with mentalizing to ignore the problem that you see. So I think the right approach is to tell a child, look, I do think there's a problem here. And I do think it can be addressed. And anything you say that is kind and interested and mindful and empathetic would probably go a long way, right? Don't do things that are feel coercive.
Mm.
Most of the time we make mistakes not because we do something, but we kind of do something that we shouldn't. And one thing you shouldn't do is become coercive. All right. But don't ignore the problem either. So you're always trying to balance things in a way that won't lead you to the extremes. Okay. And talk with the parents if it's a student, if it's somebody who's underage, talk to the parents and see where it goes. It all happens in a dialogue. It happens in a conversation.
Thank you for that. That's really helpful. I like what you said there about not being coercive. And again, it goes back to being curious. It's just I think some students would even just appreciate somebody noticing.
Yeah, for sure. The worst thing you can do is not notice. That would lead, generally people with eating disorders, they notice that you're trying to avoid the issue. So if you let
Mm,
it, if you just avoid the issue, it's just going to get worse because this has, particularly weight loss, it has an addictive component in it. Okay, so the person doesn't want to let it go very easily, especially in a cultural environment like ours, where the patient might get a lot of social reward for what is happening to their body. Right? All of
yeah.
a sudden, a friend comes and says, "Oh, you look good." That leads
Mm,
me a reminder here. If you're a family member, do not make comments about how they look to you. Do not make comments based on the body, and do not make comments based on how much or how little you're eating, because things like this happens is that the patient recovers some weight and somebody comes and says, "Oh, you look good." But for them, they don't look good,
yeah.
right? For them, it might feel like you're saying, you're telling me I'm normal. You're telling me I'm fat. You're telling me I failed with my eating disorder, and that leads them into a non-mentalizing zone. So these are like caveats to keep in mind.
What you just said, Daniel, just reminded me, and this is more of an anecdote, but at least in the Chinese culture, there's such a generational gap. When we see the older generation, like one of the first comments they'll make is, "Oh, haven't seen you in a long time. You've gained weight." Right? And what is it, like 10 pounds? Or like they'll say, "Oh, you're so skinny, you've lost a lot of weight." Like that's the first thing they'll say. And being a part of my generation, we're noticing it a lot more. And we're just so much more mindful of not doing that with our own children. Because to us, when we hear from the older generation, it doesn't feel good either. Like when they say, "Oh my gosh, like it's been 6 months, like you've gained a lot of weight. How are you doing?" And it's like, that sucked. I didn't want to hear that as the first
Of
thing.
course. Yeah, yeah. And looking at it from the point of view of the person receiving this comment, if you know yourself, if you're confident, if your mentalizing is relatively healthy, it doesn't matter. You move on and your mind will go elsewhere and you'll just go about your day. But if you can't do that, because that's an area that has challenged you, it has worried you, you have become obsessed with it, you don't have the capacity to mentalize in that area, you get stuck in that mud. And that really, really gets to you, literally under your skin, right? So it becomes very, very difficult.
I could just imagine the listeners back home and other places just going like, "What? I can't comment on my kids, physical appearance anymore." And I often think about, it's the impact over the intent. And so you might have the best of intentions, but it's the impact that it has on the other person. And I think you're really highlighting that for this population, that the most well-meaning comment could actually be quite harmful or difficult for someone else. And to really, from a mentalizing perspective, get out of your own mind and your own intent and really pay attention to the person that you're making these comments towards.
Yes, for family members, for clinicians, for friends, and so forth, they will find themselves thinking about things that they didn't before, about how to address this problem. right? And it makes us use our mind in a different way, So particularly if you are treating this type of problem, get yourself educated about these things. Get yourself educated about how these things that you wouldn't suspect, but it sounds in a certain way to the patient or to the person that is struggling with these type of problems.
This was such a fascinating conversation, Daniel, and I think Dave and I could go on and on just picking your brain about all the things around eating disorders and mentalization. But with the interest of time, I'd love to continue this conversation later on and have you back on. I think this would be great. Dave and I always do something at the end of an episode, which is to take away something away from the conversation. And Daniel, you can join in with us if you like. It's completely up to you. But Dave, I'm going to start with you this time, as many times I do. Do you have a takeaway that you would like to share?
I'm going to go right back to the beginning. Again, I think it was so important to hear that it's the behavioral manifestation of a mental distress, right? And so I think quite often people, and myself included, might be focused on the behavior and not the mental distress or what's underneath that kind of. We've touched on it today with the, not good enough or perfectionism, like looking at where the distress is coming from. And Daniel, you corrected me when I said, or you added to what I said about, the season and all the food that people are having or the family events. And you said, yes, it could be very stressful. And I'm going, oh yeah, right. The stress will affect the behavior, right? And really looking at the connection between those, I think, is my takeaway from today.
For myself, I think it's the reminder, always be curious and to build a relationship with the person in front of you and not falling into the trap of, if somebody asks, tell me what to do, don't fall into that trap of actually telling them what to do. I think it goes into an example of, in recent years, a particular client who, had that issue of pulling clinicians into that trap. And I'll never forget that particular person telling us that, nothing has ever helped. Nothing has ever helped. And I remember just suggesting to one of our clinicians, really try to build a relationship. They might be testing the waters a little bit because they're telling us, oh, this clinician gave up on me and that clinician gave up on me, the hospital gave up on me. It's like, okay, here's the pattern. We can't give up, right? Because if we give up, they're just going to go to the next person and the treatment is just going to not happen. It's just going to continue to be a cycle. So let's really try to understand the person in front of us and show them that we're not going to give up.
Yeah, absolutely. And I think what I would add to this is that I like to say that a good treatment of whatever sort has the effect of humanizing relationships, particularly humanizing also the relationship that the person has with their life and with themselves. And why am I saying this is because one way to understand eating disorders is that the person tries to make sense of themselves and try to make sense of their experience by resorting to physical stuff. They try to find themselves in the shape of their body, in the amount of calories they eat, in the amount of exercise they do, etc., etc. All things that are they're not of a relational sort, they're not of a human sort, and they can become very obsessed with this. So hopefully when things go well and when the treatment team is invested and interested in the patient, they slowly turn away from things like calories and measures and so forth. And they become interested in things of the mind. They become interested in others and they become interested in how others can think of them and what that means.
Dr. Daniel, thank you so much for being with us today. Again, just a fascinating conversation, and I really hope that you'll consider coming on again in the future, because I know Dave and I have probably 100 questions each just to just to continue our curiosity into your field. So thank you so much for being with us. Again, this is a conversation with Dr. Daniel Rochman from the University of Alberta, and it's just been a great conversation. So if you've enjoyed this episode, please follow, leave us comments. We love to hear your responses and answer any questions that you may have. And until next time, take good care.
It's been a pleasure. Thank you.